Nasal hyperreactivity is a common feature in both allergic and non-allergic rhinitis. Nasal hyperreactivity is an increased sensitivity of the nasal mucosa to various nonspecific stimuli. Both allergic rhinitis, R, and non-allergic rhinitis, NAR, patients can elicit nasal hyperreactivity symptoms. Differences in the prevalence or type of nasal hyperreactivity in R and NAR patients are largely unknown. We found no quantitative or qualitative differences in nasal hyperreactivity between R and NAR patients. It is not possible to differentiate NAR subpopulations based on physical or chemical stimuli. Nasal hyperreactivity and inflammation. The history of allergic disease goes back to 1819. When Bostock described his own periodical affection of the eyes and chest, which he called summer catarrh. Since they thought it was produced by the effluvium of new hay, this condition was also called hay fever. Later, in 1873, Blackley established that pollen played an important role in the causation of hay fever. Nowadays, the definition of allergy is an untoward physiologic event mediated by a variety of different immunologic reactions. In this review, the term allergy will be restricted to the IgE-dependent reactions. The most important clinical manifestations of IgE-dependent reactions are allergic conjunctivitis, allergic rhinitis, allergic asthma and atopic dermatitis. However, this review will be restricted to allergic rhinitis. The histopathological features of allergic inflammation involve an increase in blood flow and vascular permeability, leading to plasma exudation and the formation of edema. In addition, a cascade of events occurs which involves a variety of inflammatory cells. These inflammatory cells migrate under the influence of chemotactic agents to the site of injury and induce the process of repair. Several types of inflammatory cells have been implicated in the pathogenesis of allergic rhinitis. After specific or nonspecific stimuli, inflammatory mediators are generated from cells normally found in the nose, such as mast cells, antigen-presenting cells and epithelial cells, primary effector cells, and from cells recruited into the nose, such as basophils, eosinophils, lymphocytes, platelets and neutrophils, secondary effector cells. This review describes the identification of each of the inflammatory cells and their mediators which play a role in the perennial allergic processes in the nose of rhinitis patients. Nasal hyperreactivity in allergic and non-allergic rhinitis, a potential risk factor for nonspecific building-related illness. Schusterman D1, Murphy M.A. Author information. 1. Department of Medicine, University of Washington, Seattle, Washington 98104, USA. Dennis 3 at u.washington.edu. Abstract. Self-reported non-allergic nasal symptom triggers in non-allergic, vasomotor, rhinitis overlap with commonly identified environmental exposures in nonspecific building-related illness. These include extremes of temperature and humidity, cleaning products, fragrances, and tobacco smoke. Some individuals with allergic rhinitis also report non-allergic triggers. We wish to explore the phenotypic overlap between allergic and non-allergic rhinitis by ascertaining self-reported non-allergic nasal symptom triggers among allergic rhinitics. 60 subjects without work-related respiratory exposures or symptoms, aged 1968 years, stratified by age, gender and skin test proven, allergic rhinitis status, were queried with regard to self-reported non-allergic nasal symptom triggers, aggregate score 08. In this sample, the number of self-reported non-allergic triggers was bimodal, with peaks at 1 and 5. 42% of seasonal allergic rhinitic subjects reported more than 3 non-allergic triggers, compared with only 3% of non-allergic non-rhinitics, p0.01. Subjects over 35 years were more likely to report 1 or more non-allergic triggers, particularly tobacco smoke, p0.05. Allergic rhinitics reported more non-allergic symptom triggers than did non-allergic, non-rhinitics. as indexed by self-reported reactivity to nonspecific physical and chemical triggers. Both non-allergic rhinitis and a subset of allergic rhinitis may constitute susceptible populations for nonspecific building-related illness. Practical implications. Judging by self-report, a substantial subset of individuals with allergic rhinitis along with all individuals with non-allergic rhinitis, by definition are hyperreactive to non-allergic triggers. There is overlap between these triggers, elicited in the process of obtaining a clinical diagnosis, and environmental characteristics associated with problem buildings. Since individuals with self-identified rhinitis report an excess of symptoms in most epidemiologic studies of problem buildings, even in the absence of unusually low allergen levels, rhinitis may be acting as a sentinel subgroup when indoor air quality is suboptimal. Together, non-allergic rhinitis plus allergic rhinitis with prominent non-allergic triggers are thought to constitute approximately 1/6 of the U.S. population. Mid 17,661,929 DOI 10.1111/J.1600 0668.2007.00482.x